We have, of course, snow days for the last couple of days, and we're having it all virtual. I know last week also we had to kind of, on an emergency basis, convert it to all virtual. So hopefully we'll be back doing some in person later next week. So today we have Dr. Balamurugan Appakalai. We call him Bala, who will be talking to us about the topic of eyelid isolation for allo and auto-eyelid transplantation. Dr. Bala is currently a professor in the Department of Surgery and Pediatrics at University of Cincinnati. He also holds a faculty appointment with us here as associate professor in the Endocrinology division. He obtained his Ph.D. from Christian Medical College, Vellore in India. He then went to Japan for a year, and subsequently he was at Pittsburgh and at the Barbara Davis Center for Childhood Diabetes and at the Schultz Diabetes Institute in Minneapolis, all high-powered centers for transplantation. And he came to Louisville in 2014. He set up the Islet lab here for human islet transplantation, and we have had over 55 auto-eyelid transplants done here at Jewish Hospital from the isolation work that he has done over here. He has had a long interest in the study of islets, both islet physiology and also in developing new techniques of isolating and purifying islets for better outcomes. He developed protocols that have been used in the NIH Clinical Eyelid Transplant Consortium trials and in the auto transplant programs worldwide. He's probably one of the most experienced in this field, and we are happy to have him here talk to us about this topic of human eyelid isolation. Dr. Bala?
Yes. Thanks, Dr. Mokshakundam, for your kind introduction and allowing me to present this unique topic. It's called Techniques of Human Eyelid Isolation. This is a very unique aspect. It involves a lot of eyelid biology work plus clinical transplantation. So I would like to share how we really isolate the eyelid cells for our eyelid cell auto-transplantation and allo-transplantation. I would like to. So in the disclosure, I'm one of the co-founders and a consultant for Coligo Therapeutics. This is a kind of spin-out from our UofL, primarily to prepare human eyelid cells for remote processing and shipping eyelid cells to other centers. So in today's topic, I would like to cover the basic technique of human eyelid isolation, how we do this, and what is the current problem related to eyelid isolation from brain dead donors, which is for our allo transplant, and the other problems which are related to eyelid isolation from chronic pancreatitis pancreas for our auto transplantation, and plus other aspects of what are the major differences between, in terms of eyelid processing for auto and allo transplantation, and of the limitations and potential solutions. Isolated islets of Langerhans are a great source of cells for transplantation to cure type 1 diabetes and for understanding the molecular pathways involved in glucose sensing and insulin secretion by the beta cells, which ultimately help to design the treatment strategies for type 2 diabetes. Eyelid isolation from human pancreas or a larger animal pancreas is somewhat a specialized technique because the islets are well buried inside the extracellular matrix surrounded with the exocrine cells in the human pancreas. These are the isolated islets of Langerhans under a dissecting microscope, and they are stained with dithizone. It's a zinc binding substance. So what we transplant, we don't transplant just beta cell alone. We transplant the entire islet. So we need to have paracrine interaction from beta alpha cell, D cells, and the pancreatic polypeptide secreting cells in order for the beta cells, proper function as well as survival of the islet cells. So once the islet cells are separated from the native pancreas, they are routinely used for islet cell autotransplantation, allo-transplantation, and xenotransplantation, as well as for various diabetes research. In the case of islet autotransplantation, this is mainly for patient undergoing pancreatectomy secondary to chronic pancreatitis, and allotransplantation for brittle type 1 diabetic patients utilizing brain dead donor human pancreas for those patients, and the xenotransplantation of pig islet cells with the aim of transplanting those islet cells to future type 1 diabetic patients. As of now, predominantly we use xeno islet cells in non-human primate model for testing their functional survival. And isolated islet cells, especially from type 2 diabetic donors, are in a lot. These are the excellent cells for our basic research, and they are in high demand, especially from type 2 diabetic donors. And in the case of islet autotransplantation, pancreatectomy is commonly done in the hospital. As soon as the pancreas is available, we take the pancreas to our clean room facility, isolate the islet cells in the clean room facility, and inject the islet cells back to the same patient within 5 to 6 hours duration. We inject the islet cells into the portal vein so that the islets will be embolized in the liver and start secreting insulin. In the case of islet allotransplantation or for islet cells for basic research, we accept pancreas from many organ procurement organizations, many OPOs. They supply human organs. We accept the pancreas based on a standard acceptance criteria. We isolate the islet cells and culture the islet cells for up to 72 hours before infusing the islets into type 1 diabetic patients. Of course, the patients will receive immunosuppression. Before we transplant the islet cells, we need to check the viability, purity, endotoxin level, insulin secreting capacity, gram stain plus 14 days microbial culture, islet number, purity level. There are many release criteria are necessary before we release the product. So this product is, in order to do this islet cell allotransplantation, we have to have an IND and register in FDA's website, and we start processing these organs for allotransplantation. In the recent times, we need to have BLA, biological licensor application, in order to do islet cell allotransplantation as well as for getting reimbursement from the insurance companies. The islet allotransplantation, it involves multiple steps, including pancreas procurement, special transport of the pancreas, use of special recent modern collagenase for digesting the pancreas. Ultimately, we transplant the islet cells after culturing up to 72 hours. For human islet isolation, for clinical transplant, we process the pancreas in a dedicated clean room CGMP facility following FDA's standard regulatory standards. For human islet isolation, we need 4 to 5 members continuously work for 5 to 7 hours to collect the islet cells. That is depending upon the nature of the pancreas. The duration varies from 5 hours to maximum 7 hours. The basic method of islet isolation is intraductal injection of enzyme collagenase to digest the pancreas to release islet cells as well as exocrine cells. The intraductal injection of enzyme collagenase, it basically the collagenase enzyme digests those collagen fibers. They hold these all the parenchymal cells. So during the digestion process, the whole entire pancreas will become like a cell clusters like this. And this is like an undigested portion. Predominantly, we can see a duct. And from a 100-gram pancreas, we may get 30 to 40 ml digested tissue. From this, we separate the islet cells. We purify the islet cells using COBE2991 cell processor. This is based on cell density gradient. We use a cell density gradient, and based on the cell density differences between exocrine cells and islet cells, we can purify the islet cells. During the islet isolation, we can see the islet like this with the didizone stain. These are all exocrine acinar cells. We use Riccardi chamber to digest the pancreas, and these are purified islet cells after using the COBE. So from a 100-gram pancreas, at the end, we may get 2 to 3 cc final islet product. So this is ready for transplantation with the help of interventional radiologist or by mini laparotomy procedure. We can infuse the islet cells in a safe system. And predominantly, there are two different challenges when we isolate islet cells for auto-transplantation or allo-transplantation. For example, this is from a brain-dead donor pancreas, and this is from a chronic pancreatitis pancreas. Isolating large quantities of high-quality islets from every processed pancreas is absolutely necessary for a successful transplantation program. Islet cell autotransplantation is gaining acceptance for the treatment of severe type 1 diabetic patients, but human islet isolation remains a major challenge. Despite significant efforts to standardize the islet isolation procedures, the outcome of human islet isolation remains highly variable and unpredictable. The procedure of human islet isolation is complex and requires a great deal of experience to yield sufficient islet cells for transplant. If we don't get enough islet cells to transplant, because we need minimum of 350,000 from a brain dead donor for our allo-transplantation. But in the case of auto-transplantation, it varies. There is no real release criteria, because we don't consider any failed isolation because again there is no kind of special criteria. We need to achieve these many islets. Any number comes from these chronic pancreatitis pancreas, we have to transplant. But extracting islet cells from chronic pancreatitis pancreas is a specialized technique when compared to healthy brain dead donor pancreas, because of the structural changes within the pancreas. And substantial islet isolation technology have occurred during the past decade. However, it is still difficult to recover adequate quantity of islet cells for transplant. Indeed, even in the leading center, a transplantable yield of isolated islet cells are commonly obtained from less than 50% of the pancreas is processed. Because from every pancreas, we need at least or more than 300,000 islet cells, because the way our release, the release criteria is, we need to transplant 5,000 islet cells per kilogram body weight for the recipient. If the recipient is 70 kilogram, minimum we need 350,000. Below that, we cannot infuse those islet cells, and we consider that as a failed isolation. Yeah, a major obstacle to successful human islet isolation has been the inconsistent in islet yield. This inconsistency in islet yield have been reported by many groups, but this is kind of my own experience. This is 185 consecutive human islet isolation. This is my experience at the University of Minnesota. We have used all the modern collagenase protease enzyme. It is not like historically we used a crude type of enzymes. Using even this modern enzyme, still you can see large variation on islet yield. We have, although we had obtained high islet yield in many cases, but in some islet isolation, we experienced really low islet mass. These pancreases were accepted based on a standard donor acceptance criteria. So there was a donor selection was done. Even then, sometimes we obtained low islet mass. So this data from Clinical Islet Cell Consortium clinical trial data, here the data is from 324 human islet isolation, from multiple centers using a unified donor acceptance criteria, plus using all the modern purified form of collagenase and protease, even GMP grade standard collagenase and proteases. Even then, the success rate was 52%. So in this case, when we say failed isolation, we didn't reach the number like at the 5,000 islet cells per kilogram body weight for the recipient. So various factors, for example, each human islet isolation is different and unique due to the number of donor factors that profoundly affect the islet isolation outcome. It starts from age, height, weight, BMI, and predominantly how the cause of death, was there any anoxia or downtime, plus medical social history and increased biochemical values, plus pancreas procurement technique. The cold ischemia is a major factors which can influence the islet yield, plus the donor management in the operating in before the pancreas, before the procurement, how the donor was managed. So many factors really affect the pancreas, and accordingly we see a different type of trend in our islet yield. Many studies have reported the correlation of islet yield with the donor factors. Overall, pancreas quality has been documented as a major determinant of islet isolation yield. Factors such as elevated body mass index and the increased pancreas weight have been documented to be among the best predictors of successful islet isolation outcome. Factors such as donor age, extended cold ischemia time, and elevated biochemical lab values have consistently been found to negatively impact the islet isolation outcome. The other variables, before I go into body mass index, the other variables such as donation after cardiac death, DCD donors, in which how long is the downtime, plus types of enzyme used. The enzymes are available from 3 different companies with different proteases. For example, some companies, they supply thermolysin as a protease. Other companies use neutral protease. Then there is another compound called BP protease. So the type of enzyme used in the digestion process, cause of death, and then organ preservation method are still controversial, but with respect to their role in isolation outcome, but those factors definitely contribute for the islet yield. Then identifying donor-based specific marker of islet isolation success may indeed provide a meaning of improving the success rate of subsequent islet transplant. And one of the main factors is consistently showing better outcome is body mass index. So when we accept the donor pancreas, we look for basically higher BMI donors. Those donors, they consistently provide high islet mass. Regarding BMI, several groups have indicated that BMI positively affects islet yield, leading many to consider BMI as an important donor factor influencing islet isolation outcome. The observation is in universal agreement with the several published reports showing that islet isolation using pancreases from overweight and obese donors are consistently superior in islet yield. Before we accept the donor from obese donors, we want to make sure they are not type 2 diabetic. So we will make sure the hemoglobin A1C values before accepting those organs. High BMI is generally basically the point is if it is above greater than 25 is kind of our cutoff when we accept the donor, and generally lots of surface and infiltrating fat. Before I go in this, so generally lots of surface fat and the infiltrated fat can be seen in high BMI pancreases. and usually the pancreas texture is very firm, in those cases. So I think I can show you some slides here. Missed that slide. Okay. So as I said, there is a large amount of surface fat and infiltrating fat in those high BMI donors. And really, we don't know exactly how the BMI really helps to get nicer free islets. Obviously, the number of islets in those organs are, the mass is very high. Plus, the isolation factors, many isolation factors during our isolation procedure helps to get many free islets from those ones. And this particular study, in the study by Dr. Peter Butler group, examined a human autopsy pancreas from 167 non-diabetic individuals, 22, 100 years of age. The effect of obesity on beta cell mass was examined in 53 lean and 61 obese subject, and the effect of age was examined in many cases. Basically, the study result showed that fractional beta cell pancreas parenchymal area is about 30% higher in obese compared with the lean group, and beta cell mass is about 50% higher in obese donors compared with the lean donor. Both the fractional beta cell area and then calculated beta cell mass are increased as a function of body mass index. There was a significant positive correlation of BMI and beta cell mass. So I think this is the only study which showed some proof of concept that in higher BMI donors, the beta cell mass as well as the islet area and parenchymal volume plus pancreas weight are greater when compared to lean donor. And apart from age and gender, there are many factors contribute for the increased pancreas weight. So another factor which we commonly see, larger the pancreas, we get larger islet cells. So in many published studies, again, pancreas weight was found to be positively associated with the age and body weight. Pancreas weight has not been considered as a donor selection criteria because the value cannot be obtained prior to organ procurement. However, from Edmonton group, they reported a larger pancreas contains a higher islet mass. The study developed a formula. In this particular study, they developed a formula to kind of predict the pancreas weight. So, but in the study, it is very clearly reported that the donor body weight influenced the pancreas weight in this particular study. So, according to Dr. Edmonton group, Dr. Tachiakin reported the study. This study developed a formula to predict pancreas weight by analyzing data from 345 deceased donors. The key observation made by this group were male donors have a larger pancreas than female donors, and the pancreas weight increases with age, reaching a plateau in fourth decade. And the BMI correlate with pancreas weight, but the body surface area is the better predictor for pancreas weight than BMI. So sometimes, as you all know, BMI can mislead. If the donor height and weight, or the height, especially the height is shorter, the BMI will be very high. So, but the body surface area clearly predict the approximate weight of the pancreas. So larger the pancreas, we get larger tissue mass. So we need more than 350,000 to 400,000 islet cells for a transplant. If the pancreas weight is generally greater than 90 grams, if the pancreas weight is below 80 grams, it's very difficult to achieve larger tissue mass. And then the other factors Donor age is an important determinant of outcome of the eyelid isolation procedure. Many studies reported that transplanted eyelid preparation from younger donors are associated with better clinical outcome. Basically, from a younger group, their functional capacity is high. Generally, pancreas is small. Then we face a unique problem. We get mantle islets from younger donors and large tissue mass. Because of the mantle nature of islet cells, we have a large tissue mass. But in older donor, generally the eyelid isolation procedure is somewhat very straightforward. So we don't have any major issue in terms of eyelid processing. But the quality of islets compared to younger donor is somewhat inferior. For example, we consistently see their functional capacity, high insulin secretory capacity, plus transplant diabetes reversal capacity in animal model. We see with the younger donors compared to older donor. Then naturally, the islet graft isolated from younger donors allows superior functional outcome. Basically they are from their capacity is high, their diabetes reversal ability is very high in those donors. But the main problem is we get large amount of mantle islets from these younger donors. The islets are still embedded inside the exocrine compartment. As you see here, they are not free islet cells. They are surrounded with the exocrine cells. So the problem is it's difficult to purify these islet cells if they are heavily embedded like this. That's one of the challenges for us to collect these mantle-free islet cells from younger donors. The islet isolated from younger donors remain mantled and embedded by surrounding exocrine cells after enzymatic digestion of the pancreas. Though the surrounding layer of acinar cells may protect islet integrity, but mantle islets are often lost during our purification process because they are not free from the exocrine cells. And the release of mantle islets from younger donor pancreas is likely due to the composition of the extracellular matrix. And we obtain large tissue mass from those younger donors compared to older donors. And in order to standardize to get mantle-free islets, we attempted eyelid isolation from many younger donors. During my tenure working at the University of Pittsburgh, we had the opportunity to process many young donors, including 6 months old human donor. We developed a young donor protocol. In that approach, we prolonged the enzyme distension step for over 25 minutes to allow the pancreas to digest in static digestion condition. We wanted to minimize the mechanical digestion in Ricardi chamber. At the same time, we prolonged the static digestion approach using the collagenase protease enzyme blend. So that really helped to get many free islets. So this is the nature of if we don't do the young donor protocol, we get a lot of mantle islets, and these are the free islet cells we obtained with that approach. This study was reported, in the year 2003. But now with the newer enzyme, we need to the enzymes which we have used, back in 2002, 2003, it is not available during this present time. And using the modern enzyme, again we are getting a lot of mantle islet cells. And we standardized various enzyme combination and ratios in split model lobe, and using a higher protease enzyme dose, we consistently get mantle-free islet cells from those young donors, and it's easy for us to purify. And when we transplant these islet cells, they really continue to function for a prolonged period of time. But now I'm kind of switching from brain dead donor isolation to chronic pancreatitis eyelid isolation. As you see here, Isolating islet cells from chronic pancreatitis pancreas poses multiple challenges: alteration in ductal structure, calcification in ducts, and the accumulation of fibrous layers in the parenchymal. It's difficult to inject the enzyme through the pancreatic duct. So if you compare the gross morphology of brain-dead pancreas with the chronic pancreatitis pancreas, you could appreciate the difference. Histologically, in microanatomy, we see large variation in islet architecture. The parenchymal volume, it varies a lot from mild cases to moderate and severely fibrotic cases. For example, in these cases, the total parenchymal mass itself very low. It's difficult for us to isolate islet cells from these type of organs. When we compare minimal change chronic pancreatitis cases with the brain-dead donor pancreatic islets, we get a similar number of islet cells. Actually, it's more than 4,000 islet equivalents per gram pancreas. It's an excellent islet number. So we get a comparable islet yield with the minimal change cases versus brain-dead donor pancreas. The degree of fibrosis affect the islet yield, and the degree of acinar atrophy causes lower islet cell mass from these cases. So whenever we have a pancreas from minimal change or moderate change, we don't need to worry about our islet isolation procedure. But from a severe cases, we have to alter a lot of techniques in order to digest the pancreas to release islet cells. The common problems we encounter during chronic pancreatitis, severely fibrotic cases, many times we see dilated duct or sometimes calcification in the duct. In those two scenarios, it's difficult to distribute the collagenase protease enzyme throughout the pancreas. And because of severe fibrosis nature, because there is no parenchymal cell at all, it's mostly fibrous tissue. In order to reach some portion of parenchymal cell, we have to do all kind of modified approaches to reach those regions. And we want to make sure the enzyme, the collagenase and protease which we reach, they reach those islet exocrine phase and release those islet cells. Our primary goal when we process pancreas for auto transplant, our cutoff is we try to minimize the undigestion of the pancreas. For example, these are the classical examples from brain-dead donor pancreas. It's a very straightforward technique. If you use the right enzyme blend, we digest almost the entire pancreas. This is just a ductal structure, and this is the undigested portion of the pancreas. But this is the common problem from chronic pancreatitis cases. We see large amount of undigested tissue, and from these ones, for example, these are all nice parenchymal cells. Obviously, we lose a lot of islets in those parenchymal cells. And this is a better example for minimal undigested tissue from a chronic pancreatitis pancreas. Here you can see most of these ones are non-parenchymal cells. So we got a large number of islets from this particular type of preparation. And we use many modified approaches. For example, in the case of brain-dead donor pancreas, we just commonly use, or the standard protocol is, use of one vial collagenase and protease enzyme regardless of the pancreas weight or texture of the pancreas weight. But in the case of chronic pancreatitis, we have to dose the enzyme according to the severity of fibrosis. And we inject the enzyme using controlled, pressure-controlled equipment. But in CP cases, we have to use a hand syringe injection in order to feel the pressure and inject the enzyme throughout the pancreas. If we rely upon using pressure-controlled enzyme distension procedure, sometimes we don't deliver the enzyme properly. Plus the other factors, the enzyme distension for a prolonged period of time In brain dead donor pancreas, predominantly it's 12 to 15 minutes, but here we have to really go for a prolonged time in order to digest the pancreas. And many times we need to inject the pancreas directly into the pancreatic parenchyma because we cannot really inject the enzyme through the pancreatic duct. But in a normal pancreas, it's a very straightforward approach. We don't need to inject directly into the pancreatic parenchymal cells. And we don't need to do enzyme recirculation for a normal pancreas, but here we need to do enzyme recirculation approach. And the other important aspect is large variation in extracellular matrix in chronic pancreatitis pancreas. So we have to make sure our enzyme is capable of digesting these fibers. It's easy to digest these normal pancreatic parenchymal cells because of large amount of this extracellular matrix. We have to make sure our enzyme is capable of digesting those fibers. For example, in a normal pancreas, we can see the collagen 1, 4, 5, 6 and all. They distributed somewhat like uniformly in the pancreas. But in chronic pancreatitis cases, those fibers are highly expressed. Sometimes we see more than 1,000-fold increase in various fibers. And especially, for example, we see type 6 collagen levels are very high, laminin levels are very high when compared to normal pancreas. So we have to make sure we have to supplement enzymes which are capable of digesting these type 6 collagen and laminin and all. So that's kind of our standard approach for chronic pancreatitis. And we for developing enzymes which is highly suitable for our auto transplants, we have to do a lot of HPLC analysis plus biochemical assays of our collagenase so that we can select the best enzyme combination. For example, we need a higher proportion of intact C1 collagenase for digesting CP pancreas. And for normal pancreas, we need a more collagen 2 enzyme for better digestion and the release of islet cells. And nowadays enzymes are available from 3 major companies, Vidasite, Serva and Liberase. They supply, these enzymes are purified form of enzymes, and these enzymes, they come with the different proteases. Some are thermolysin, neutral protease or BP protease. For our study, we identified the best collagenase from a company, from one particular company, and mixed with a neutral protease from a different company. That enzyme combination, it really help to really digest the pancreas thoroughly. And for example, in this study, we had like over 90% digestion from chronic pancreatitis cases using those new enzyme mixture formulation. In the entire islet isolation process, delivering the enzyme is the key. If we don't properly deliver the enzyme throughout the pancreas, we don't digest the pancreas to release islet cells. So we make sure using the pump system or by hand syringe, through the parenchymal injection plus through the ductal injection, we kind of inject throughout the pancreas to make sure all portion receive the enzyme. And as I said, this is a typical direct parenchymal injection into the pancreas because these are all severely fibrotic, and we cut the pancreas into multiple pieces so that they expose the enzyme solution for better digestion. And we also developed this enzyme recirculation approach to digest the undigested portion of the pancreas. So this approach is commonly followed for our Allo-Transplantation cases. So in which during digestion procedure, we open up a system and collect the enzymes, collect the cells with the enzyme solution, and separate the pancreatic cells, and then add the enzyme back to the circulation so that it continue to digest the undigested portion of the pancreas in this recirculation approach. So after best enzyme delivery after selecting, after doing the proper digestion as well as injection step, the other common challenges we face is purification. Whenever islets are free like this, it's easy to separate these islet cells, but it's difficult to separate these type of embedded islets from these exocrine cells. Generally, purification step we lose islet cells. The common recovery from any type of gradient purification approach is 65 to 70%. We tend to lose almost 30% of islet cells during the purification process, regardless of the different density gradients are used. We predominantly use Ficol gradient, OptiPrep gradient to separate the islet cells from the exocrine cells. And we developed some kind of analytical gradient approach to identify the optimal density for purifying the chronic pancreatitis parenchymal cells, because the density of the parenchymal cells from autografts were different from allo-pancreases, basically like a brain-dead donor pancreases. The chronic pancreatitis pancreas comes from a living donor with a short cold ischemia time, but brain-dead donors generally they have a longer cold ischemia time, and brain-dead alone may cause us a lot of changes to the pancreas. So naturally, there are distinct densities between these two preparations. So if we use the standard purification approach, generally we lose a lot of islet cells with the standard density gradient approach. But generally the commercially available gradients are predominantly for our brain-dead donor pancreatic islet cell purification. There is nothing is available for our chronic pancreatitis cases. So based on this analytical density gradient system, we identified the optimal density for purifying from a chronic pancreatitis. Generally, for example, in the case of brain-dead donor, when we purify the islet cells, the purity level is usually more than 60 to 70%. We get somewhat like a purified islets with the minimal exocrine cell. But for our chronic pancreatitis pancreas, our goal is to reduce the exocrine cell mass. Our purity may be the same, purity level before and after purification. It won't be a big difference, but our goal is to reduce the exocrine cell mass without losing the islet cells. So we use two different approaches for CP cases versus our brain-dead donors. This, for example, this data clearly shows, we could reduce the tissue volume from 30 cc to 11 cc. This is the transplanted pellet size. So this is what initially we obtained. But with the recovery of 87%, but if you see the purified islet cells, they are not highly purified, but the exocrine cells, we eliminated a lot of exocrine cells for our chronic pancreatitis cases. I think with this, these are the common techniques we use for our islet isolation procedures for auto and allo-transplantation. And I would like to thank our collaborators, lab members for developing these procedures for our better islet product. So I would like to stop here and take the questions. And I believe this is the event code for today. Thank you.
Dr. Bala, there were a lot of questions on the chat box.
Okay, sure.
You want to?
Yeah.
Are you able to look at them? I think Dr. Kotwal has a couple of questions there.
Sure.
I can read them to
So
you.
yes, I see does allo-transplantation require triple immunosuppressive therapy in the recipient? The answer is yes. There is a in the recent time there is a well standardized immunosuppressive regimen is available. They start with basically the induction is ATG induction followed by low dose of sirolimus and tacrolimus as a maintenance therapy. So that's kind of our standard immunosuppressive protocol for this. And the other question is, does the enzyme treatment digest the surface protein like the
MHC.
MSC proteins? Does the enzyme treatment digest the surface proteins? It is definitely possible. Honestly, we don't know what are the surface proteins are eliminated because of this digestion procedure. But at the end, we don't know whether those surface proteins are necessary for the islet cell survival. I don't see any papers which are related to degradation of these type of proteins. Or during culture period, there may be some kind of recovery from those proteins, from the surface receptors and other things, but I don't know.
So even though you have, the people who are obese and overweight having more islet mass, the lean controls, you have less islets, but they are more efficient. Is there any correlation at all between the islet function?
Sure. For example, when we isolate islet cells for our basic research, at that time, we don't really look for obese donors. We accept whatever the pancreases are available to us. And when we compare the islet functional capacity of, lean donor with this obese donor, definitely lean donors' insulin secretory capacity is very high, compared to obese donors. But the challenge for us, if we don't get enough islets, like more than 300,000, we cannot transplant the preparation. So unless if we kind of reduce that transplantable mass, like the 5,000 islet per kilogram body weight concept, we cannot, as of now, we cannot continue to use the lean donor organs. But for research, yes, they really very useful for our studies.
Because one of the things that I see is that some of the pancreatitis patients who have normal glucose tolerance and are very insulin sensitive, so they tend to have less islets, but obviously they're very, in terms of whole body insulin or carbohydrate metabolism, it is very effective. So
yes,
you may get less islets, but that may be enough for them.
I'm sure. There are many examples like this. In the entire pancreas, sometimes I see only 20% parenchymal cells. First of all, there is no cell, very limited cell mass, including islets and the exocrine cell. So only 20%, remaining 80% of the pancreas or only fibrous tissue. But surprisingly, the patient is completely insulin free before the pancreatectomy. So that means like in that 20% parenchymal cell mass, maybe another 10%, only 10% are islet cells. I don't know how those 10% islet cells maintain normal metabolic, better glycemic control before pancreatectomy in those patients. So it clearly indicates that, it's not the number, it's the quality of the islet cells are really important for long-term insulin-free status and all. I see another question. After islet transplantation, Does the administration of insulin still required? The answer is yes. We don't want to overload the transplanted islet cells, so we continue to give insulin at least for, I would say, over a period of more than 30 days. Sometimes it's even 60 days. Patient will continue to receive insulin so that the transplanted islet cells, they are settled and engraft properly.
Dr. Bala, that was a very nice review. Thank you. As one of fellow commented, we really enjoy seeing these islet patients in the hospital and at follow-up and learn a lot from that. It's just amazing how different, like just you and Dr. Mokshigandam alluded to, the islet mass, BMI, insulin sensitivity. There's so many players in this, so it is quite fascinating. So one of the things which recently, and I think Dr. Mokshigandam probably mentioned it too, is with the COVID, the islet apoptosis, something with the similarity between how it works. Has there anything that you can comment on that?
Kind of relation with the COVID.
Yeah, so I think Dr. Mokshigandam can frame the question better.
Well, I think the paper that was written about this was, the immediate blood-mediated immune response that you get, with islet transplantation, portal islet transplantation. That has a very similar, it's a complement-mediated response and is associated with thrombosis of, which is very similar to what happens in the lung in COVID, So there's a similarity of the mechanism by which the immediate blood-mediated, immune response that you get when you transplant, because no matter what you put into the islet, into the liver, there is an immune response, which is not antibody-mediated, but it's related to the fact that something is there,
Definitely.
So that initiates this response, which is very similar to what happens in COVID.
Oh, I see.
There was a paper published looking at the common thing between these two mechanisms by which it thromboses those veins, which eventually leads to the death of the transplanted islets. So that's what they had talked about, because that's one of the limiting factors as to why islet transplants fail, even though, because in an auto transplant there is no immune reaction in terms of allo rejection, but it still initiates the immune response, which is not related to
Definitely, I think this is kind of new information to me. That's thanks for this information. But definitely, as soon as the islets are in portal vein, there is the IBMIA reaction starts, even in allo or in auto cases also it has been kind of reported. I think with a lot of anti-inflammatory drug, I think we can really minimize those ones. So I think that response, definitely it causes damages to islet cells if we don't really treat them. Otherwise, the engraftment will be a real problem.
Because there have been some reports of new onset type 1 diabetes or islet damage related to COVID itself. There are, the ACE protein is there on the islets, and it is possible for this to get in. But it's not. There's controversy about it, but there have been a couple of cases that they have reported where there's islet damage related directly to COVID.
Then I see another question, do the islet cell multiply after injection? Generally not. We lose islet cells every day because of overwork, exhaust. We see islets are exhausted after transplantation, but generally we don't see any multiplication.
That is one of our dreams to make islets multiply. So, either in a controlled manner, obviously, otherwise you'll get an insulinoma.
I think, but from the adult, I'm sure, with the recent modern clinical trial using iPS-derived beta cells, I think those cells may continue to grow even after transplant. But with the islet cells, we don't see those. Then another question is whether I can multiply them in culture. No, we don't. We cannot. Adult primary cells, generally, they don't multiply.
Okay, if there are no other questions, thank you, Bala.
Thank you. Thanks a lot.
For a very informative talk.
Thank you, Dr. Bala.
Thank
That
you.
was
Thanks a
very
lot.
See you all next week.
Yeah, thank you very much.
Bye.